Thanks, Mike, and thank you very much for the invitation to speak today. I'm hoping that I will lead on, complement Steve's previous talk around the historical perspective by talking a little bit about current perspectives and where we are today. The focus of this talk is on a piece of research that we recently commissioned Ipsos Mori to undertake. And the focus is health data, quite broadly construed. So personal health data includes genetic data, health, medical and genetic data, focused very much on the UK. So I'm hoping that this will add a little bit of empirical grist to the abstract, theoretical, philosophical mill of today's kind of conversations. So a little bit of context to the research that we commissioned. And then the picture I've got up there is the lesser spotted care.data leaflet. I'm not sure how many of you actually received that in your junk mail. But it provides a little bit of context as to the research that we did and why we undertook it. So care.data was a program that NHS England was planning to roll out back in 2014. The aim was to connect up information from GP records with those of hospital records to extract at a population level GP data into a centralised database for secondary usage. There was a significant public outcry about this idea. It came in the context of a lot of publicity around government surveillance. It was in light of the Snowden revelations and so on. Lots and lots of concern about hacking, data loss, and so on. So the sort of surveillance culture concerns were becoming very prominent in the public mind. A lot of concerns about how data is collected and used quite broadly, not specifically to medical and health data, but much more broadly than that. At the same time, though, there's been an increasing interest in the potential of big data, particularly in health, and as was mentioned before, the sort of potential economic benefits to UK PLC of using data on a large scale. So there's a real tension here between the idea of promoting data use, articulating benefits and benefits to health and also benefits to the economy, but at the same time huge concerns over loss of privacy, loss of control and so on. Why does this matter to us? Well, as a research funder, a lot of our researchers collaborate with commercial organisations. It's true, of course, that the NHS, there's a lot of commercial organisations are involved in delivering services and functions and so on. And we felt that it was kind of a good time to be looking at this key question of commercialisation, commercial access, how people feel about it. And there was a very real impact on research when care.data happened and there was a big public backlash. HSCIC, the information centre that holds a lot of the population level health data, essentially went on lockdown, and a huge number of researchers and the research projects that have been ongoing for quite some time actually pretty much ground to a halt overnight. So this does matter to research. Previous surveys we looked at indicated that in general, people are quite positive about the idea of their personal data being used for medical research. But as soon as you mention a commercial organisation being involved, that trust, that acceptability pretty much drops off a cliff. And from the previous research that's been done, we found that no one had really sort of dug into this in much depth as to what the actual issues are. Why are people so uncomfortable with the idea of companies accessing health data? And this really comes down to a question of trust and trustworthiness, as was sort of pointed out in the background paper. And we were very keen to set up this study as a way of trying to examine not how to increase public trust per se, because actually for quite a lot of commercial uses of data, they might be perfectly legitimate that people don't trust them. What we wanted to do was understand if there are steps we could take to try and increase the trustworthiness of the systems, of the governance, of the research that's undertaken using data so that people feel more comfortable about the way that their data is being used. But of course we can't just say, let's try and increase public trust, full stop. So we commissioned Ipsos Mori to undertake quite a large piece of research. The aim was to try and identify what factors influence attitudes towards commercial organisations accessing health data. We wanted to see if there were particular governance, safeguarding, communications actions that could help improve the trustworthiness of research systems and uses of data. And we asked Ipsos to undertake, first of all, a series of qualitative workshops around the country. So this is all around the UK. We had over 200 participants. We then did an interim analysis after that qualitative phase in order to design a survey. So we wanted the survey to kind of be responsive to the qualitative findings. And that was a survey of just over 2,000 people across the UK. We were keen to get a range of perspectives. We had several workshops involving the public, also patients. We had a particular cohort of rare disease patients that we recruited through Rare Disease UK because we thought it would be interesting to see if they have a different perspective on commercial access. A few groups of GPs and hospital doctors who have obviously a particular responsibility towards their patients when it comes to how their data is managed. And we also recruited a group of our research cohort members. This was from ALSPAC, the Avon Longitudinal Study of Parents and Children. And we had a group who were in their 20s. They had actually been part of this research cohort since birth. And we thought it would be interesting to see if, as a result of being embedded and involved in research throughout your life, do you have a different perspective on commercial access to data? So this was the sort of structure of the research. And we built it around real-life case studies. So rather than asking people, how would you feel about a pharmaceutical company accessing your medical record, which is what previous surveys had sort of done with that level of detail, we worked quite hard to try and get some real examples of what kinds of companies use data, why they use it, how they use it, what the protections are that are in place. We wanted to base it on what actually happens in practice. And we tried to get a full range of different kinds of organisations involved. So I'm very happy to go into more detail about what the case studies were in the questions, but just for now, here's a kind of a brief overview. We had everything from a Dr. Foster-style data linking and analysis in the NHS, an intelligence company working with an NHS trust to, for example, map out patient pathways and so on. We had an example from the insurance industry that was based on a paper that was published in December 2013, an actuarial society that used hospital data about diagnoses and hospital admissions to find that those living in deprived areas were more likely to develop certain critical illnesses. This was something that caused a huge amount of controversy when it was reported in the media. Also, pharmacists using summary care records. So this is a plan that's actually, the intention was to roll out across the country. At the moment, your GP can access your summary care record, A&E, some services, but rolling it out into pharmacies as well, again, generated some controversy when that was announced. We had an example from using genetic data in care and research based on Genomics England practices. And we also included something about crowdsourcing. We wanted to see if people were kind of up to speed on new digital technologies, the idea of patients actually having control of their data and deciding what they wanted to do with it. We were very keen to ensure that this is not just about good news stories and look at all the great things you can do with data. We wanted to use really controversial scenarios as well, hence the insurance example. And we added sort of what-if scenarios to all of these case studies to really try and push at the boundaries of what people found acceptable and what they didn't. So I'm going to talk to you first and foremost about the qualitative findings from the workshop, because I think that's probably what's going to be of most value to this particular discussion. But I just wanted to preface that with one of the quantitative findings, which I think helps provide a little bit of context. And that context is, in general, pretty low awareness of how data could ever be used for purposes beyond your direct care. So this slide really just shows the general low awareness of data use overall. You can see the top bar there, the people who feel like they know a fair amount or a great deal about how data is used in the NHS, around a third. Quite a chunk who know just a little, and around I think, sorry, that's that mistake on that top slide there, but quite a few who just don't know anything about it. The interesting comparison is for commercial organisations and academic researchers. In general, pretty low awareness amongst people of how data could actually be used for anything beyond giving you care and giving you treatment. We did do a little bit of demographic analysis, and there were only a couple of points that I'll point to that. But in general, awareness of health data usage was positively linked to education and also level and frequency of internet access. So with that preface in mind, I'm going to talk a bit about the qualitative findings. So these workshops were all-day workshops for the most part. They started off trying to get people to think about data use in people's daily lives and so on. And then we moved on to the case studies, and with a fair amount of detail in those case studies, and got people to think about how they felt about these case studies, what their reasons for their perceptions were, and lots of discussion among the groups. So this is quite a dense slide, but I'll just sort of walk you through it. Probably the top level finding really from this research is that as far as the tests that people go through when they're deciding if they feel like a company accessing data is acceptable or not, is why. The purpose is absolutely critical. And in general, we found in the workshops, people work through the questions as why, who, what, and how, in that order. So first and foremost, there's a why. If there is a clear public benefit, you see on the top left, that's more acceptable. A mix of public and private benefit, a little bit uncertain. Solely private benefit, and by private here I mean private commercial as opposed to private for an individual. So that really did come out absolutely top. Interesting to note here that the idea of a company being involved and being using data for research isn't completely unacceptable if the public benefit is the priority. The who is the sort of second point, that in general, if the providers their primary aim was to provide sort of health services and so on, or support the NHS, that was deemed more acceptable than any use that was not explicitly linked to improving public health or providing services. So the insurance example on this one very much fell down. In terms of the what data, this one was a source of huge confusion to the vast majority of participants. It was very, very hard for people to grasp what the difference was between individual level data, aggregate data, anonymized data, identifiable data. In general, anything that was individual level data, patient level data, was just perceived to be mine. My data, that's my data, and I should have control over it. In various ways. So it was extremely hard in the workshops to kind of keep coming back to the distinction between different types of data and different levels of anonymization or lack thereof. Interestingly, we have a box here of genetic data. It moved quite a lot along this spectrum of being acceptable and unacceptable, and particularly as people had different conceptions of what kind of data it was, whether it was identifiable or not. But if there were uncertain future implications, if it wasn't clear how the data might be used in future, that tended to push people towards the less acceptable side. Also interesting was that the how was right at the bottom. So people just assumed that there were some safeguards in place. They weren't particularly fussed about what those were, but they wanted them to be there. So essentially, all the safeguards in the world and all the governance and all the things you can put in place to protect data won't make a difference unless you've got these why and these who questions right in the public mind. In general, we found that people were very surprised at the extent of data use. It was very hard to convey why data is needed to undertake research. And although people tended to be supportive of medical research broadly, even that involving commercial organisations, there was a real cognitive disconnect between the abstract idea of research and my data. Why do you need my health record for that? Yes, of course, research sounds good and it seems reasonable that this company would be involved, but what's that have to do with my data and my personal health record? In general, the more information that was provided, the more comfortable people felt, but that wasn't a hard and fast rule. There was also quite a lot of nuance about the different types of commercial organisation that was accessing data. Insurance and marketing purposes generally perceived to be bad, no perceived public health benefit to those. But where a public good could be identified, then in general there tended to be greater acceptability. And there is a huge range of different mindsets about these kinds of different kinds of uses. One of the things that we found that the Ipsos team found from analysing the data that came out of the workshops was this idea of context collapse, which I think is extremely pertinent to today's discussions. And I'm just going to sort of talk you through these two different circles. On the one hand, when we are engaged in a commercial transaction, we have a certain mindset about it. Your data has a certain financial value, you understand, you accept that. So for example, using online banking, using loyalty cards, using social media, you don't necessarily know how your data is being used, but you sort of accept that in exchange for getting, say, discounts or ease of service or something like that, you're giving something. There's a transactional mindset there, and you might not necessarily know the boundaries of that, but you appreciate that that's what's happening. On the other hand, when you're using a healthcare service, when you're talking to your GP or seeing a specialist or attending A&E or talking to your pharmacist, you're giving information, but you don't see that in the same light. You don't see it as I'm telling you something and I'm getting a service in return. You have a much more sort of open, vulnerable mindset. You're receiving healthcare, but it's not perceived in that transactional way. What we found when we were talking about commercial companies accessing health data was that these two contexts seem to collapse into one another. So where you have a company accessing health data, all of a sudden people feel like they don't know what the boundaries are. They don't understand what those relationships are because you've taken these two mindsets that were very different, you've collapsed them into one another because you have a company, you have a commercial interest involved in your healthcare, and you don't quite understand what the nature of that relationship is. And two very sort of concrete examples from that is during the care.data debacle, there were lots of concerns raised for the status of the doctor-patient relationship. There were concerns that, if patients felt that their data might be sold on or passed on for something other than their care, they might not tell their doctor what was happening with them because they were worried about where their data would end up. On the flip side, if you are adopting the healthcare vulnerable mindset, but you happen to be in a commercial transaction, you can also be tripped up. So a good example here was where Pharmacy to You, which is an online prescription service, fell foul of, I think it was fined by the Information Commissioner's Office last year for passing on personal data from electronic prescriptions onto direct marketing firms and an Australian lottery company that was being investigated by trading standards. And there, people were collecting their prescriptions, and they wouldn't necessarily have thought my data has a transactional commercial value here. And so, I think there are just kind of two useful ways of seeing how, when these contexts collapse in on each other, you can get tripped up, and it's no surprise really that patients are particularly wary. And I think for this, it's particularly critical to recognise the impact on the relationship, the doctor-patient relationship. And I know certainly in the background paper there's a lot of discussion about the nature of medicine and the nature of commerce and what happens when they interact. But actually it's certainly from our findings, it's the concern about what happens to the relationship between a doctor and a patient when you may have a commercial interest acting in a healthcare context. So as part of the workshops, we also mapped out the case studies. We got participants into groups and asked them to map out how they felt about the different examples that we gave them. And it's quite a useful way of drawing out the nuance of perceptions of different kinds of companies and different kinds of uses. So we asked them to map with post-its on a wall and then discuss and move them around the different examples on axes of value to society on the vertical and risk to society on the horizontal axis. And there's some really interesting different perceptions of different kinds of companies and different kinds of uses of data. You'll see insurers are right down the bottom, perceived to have absolutely no value to society and pretty risky. So I think the insurance industry's got quite a task on their hands. Genetic sequencing example, interestingly, perceived as being one of the most high value to society, but also the riskiest. And this is certainly from the workshops that I attended, the perceived risk there was just, we just don't know. We just don't know how this data could potentially be used in future. Therefore, we're uncertain, and we think it's risky. Controversial what if scenarios were discussed, and actually people sort of moved these examples along the axes in different ways, depending on quite how things were being pitched. So, for example, the genetic sequencing one, we said, well, what happens if the Genomics England is sold to entirely, to an American genetics company or something like that, and the data all disappears out of the UK and goes somewhere else, and that really obviously got people very riled up. But the risk perception and the value perception shifts quite a lot depending on how you frame the issues. There was also a lot of worry about slippery slopes. So in the example of a pharmacist accessing your summary care record, the scenario in which this would happen is you go to a pharmacist to collect your prescription. The pharmacist asks, can I have a look at your summary care record? You consent if you want to, and they will check your medication against known allergies, previous contraindications for medication, previous medication history, and so on. And the idea of this is it's supposed to help pharmacists spot things like dosing errors or potential contraindications that your GP hasn't spotted. So that's the idea of it. But there was a real concern there around the sort of slippery slope of, okay, well, if my pharmacist can get hold of this, then who else could? Could a social worker get hold of this information? How far does it spread? So even if in the case of the pharmacist there could be a good clinical reason why this could happen, there was a lot of concern about, well, who else then? If it goes beyond my GP and it goes beyond A&E, where else is it going to end up? Also, the fact that a lot of pharmacists are based in supermarkets and so on generated a lot of concern. So there was a few headlines when this was trialled around Tesco accessing your medical record, which was, there's a pharmacist based in Tesco, but that doesn't mean that Tesco is getting hold of your data. But people were very, very concerned about that sort of slippery slope and where does it lead. The crowdsourcing example was interesting. We thought this one might be a little higher up in terms of value, but actually what it indicated was that digital tech's actually very, very new to a lot of people. The crowdsourcing example was based on Patients Like Me, which is an online community, a patient platform where patients with a variety of diseases, particularly rare diseases, form a community. They chat to each other, they talk about their symptoms, they talk about their treatments, there's sort of a community of solidarity and so on. And it's possible for companies to, under sort of licensing conditions, to get hold of some of that data, undertake research on it, find out if, say, an off-label use of a particular drug that hasn't actually been through a clinical trial might help improve symptoms for a certain condition and so on. But in general, it was met by bafflement by a lot of people who just didn't really understand how the use of a digital platform and use of online community could potentially help healthcare, help them, help research. So it's quite a useful kind of reminder that with all the frontiers in big data and developments in healthcare and technology, that actually a lot of people, in fact, probably most people, are oblivious to the potential of this at this point, and that certainly from the workshops that we undertook, the idea of using platforms, online communities, digital technologies to help improve their healthcare was pretty alien. So I'm going to move on to the quantitative findings and just provide a little bit of the quantitative data. It's important to note here that whereas with the qualitative research, people had several hours to get to grips with what was happening with the case studies we presented, to ask questions, to find out more about the examples that we were using. In the quantitative survey, it was pretty much cold. There was no context given. So I think this, it did create, I think, some interesting differences between the two. So the first finding is that actually, just by a very slight majority, if companies are undertaking health research, that people will tend to be supportive of it. But it's also interesting to note there's a big chunk of neither support nor oppose or don't knows in this, and actually, just over a quarter who are opposed to the very idea of commercial organisations accessing health data. Interestingly, if you reframe that slightly and say, well, if the commercial organisation is the only one that can undertake this research, and if they don't do it, the research isn't going to happen, that does seem to shift the acceptability slightly more. So it's a bit difficult to see the colours here, but essentially our survey participants were set up with these two questions. A, I would not want commercial organisations to have access to anonymised health data, even if that means the research does not take place. Or B, the research should be conducted by commercial organisations if there's a possibility of new treatments for diseases being developed. And in general, in contrast to the previous finding, where there wasn't an implication that research wouldn't be undertaken otherwise, there was a slight increase. Interestingly, we also did a split sample to see how people would feel about certain uses of health data done by a public body or a commercial organisation. We used the example of drug monitoring and set up a public health regulator against a pharmaceutical company, and actually there was not a significant difference in acceptability between those two. So the drug company wasn't a deal breaker, as it were, because there was seen to be a valuable health use coming out of it. As I said at the outset, we wanted to get nice and controversial, so we did a couple of really we thought kind of juicy examples here of insurance companies and marketing companies getting hold of data. It was interesting that these results came out as they did, actually, because we had expected the acceptability of both of these to be much lower in the quantitative work than they actually are. It may have been that the marketing example we used was for a health product. So the example was anonymised health records being used to target a low-fat margarine in regions that have higher prevalence of cardiovascular disease. So potentially that seems like quite a benign marketing example. We're not sure. It was very strong in the qualitative work that insurance was not acceptable, whereas here there was, it's still only a quarter, but there was definitely more acceptability. But in general, not hugely positive for insurance and marketing. And this is anonymised health records as well. We were interested also in the sorts of safeguards that people wanted if companies were going to have access to health data. So we wanted to see if the idea of asking permission made a difference. We didn't use the term consent just because of the difficulties of talking about consent versus informed consent and how people might perceive that. So we asked about permission. Would you like the NHS to seek permission before companies access health data? And no, this isn't your health data. This isn't identifiable health data. This is anonymised health data. We didn't explain the term anonymised in detail. The wording was that information does not contain names and addresses. And of course, there's a much higher standard for anonymisation than that. But in the context of a survey, it would have been pretty hard to delve into those kinds of issues. So in general, a slight preference for the NHS asking patients permission, 54% to 34% who said they'd rather research happens, even if in some cases the NHS doesn't ask permission. But the interesting thing I wanted to draw out on this particular slide was that it's perhaps surprising and counter to some cultural narratives around young people, that it was actually young people's willingness to share private data. It's generally assumed that younger people, millennials, don't care as much about consent and privacy and so on. But we found actually the opposite. It was the people who prioritise permission being asked before health data is shared. They're more likely to be young, 16 to 24, 72% of them wanted permission to be sought. In lower socioeconomic grades and also from a black and minority ethnic group. And those who wanted permission to be sought are generally those more likely to oppose commercial health data sharing in general, and also those who are unaware that commercial organisations actually do access health data in the first place, which highlighted to us that low information and low awareness is generally associated with lower acceptance and greater cautiousness about how health data is used. And as I say, it was quite a useful counterpoint to the assumption that that older people are going to be more cautious and younger people will be more accepting. We actually found the reverse. So where commercial organisations may have access to health data, we wanted to know, what do people want in place? What safeguards and conditions did they think were important if commercial organisations were going to have access to health data? In general, and for this question, people could tick as many as they wanted. The highest rated ones were around onward sharing, so sharing data with third parties, de-identification, sanctions and fines, the need for secure storage. Interestingly, in this, despite the fact that in the qualitative work that why question of public benefit was absolutely critical, it came sort of around midway down in the quantitative work, the clear intent that research will lead to benefits to society. For the safeguards that we inquired about, as I mentioned previously, people tended to want reassurance that there were safeguards in place, that the data was protected, but weren't particularly bothered how that was actually implemented. What I want to draw your attention to here is the 17% that stated, I do not want commercial organisations to have access to health data for research under any circumstances. Around a 17% proportion of those in the quantitative work. We didn't find such a high proportion from the qualitative work, although of course we didn't actually quantify it. In general, we found that in the workshops there were a few people that would resist the idea under any circumstances, but in the quantitative work that 17% was pretty solid. For those people who answered they did not want commercial organisations to have access under any circumstances, we asked them a further question because we wanted to know why this was the case. I'll just about read that. And interestingly, those who didn't want commercial access under any circumstances tended to cite, we only allowed them one answer to this, tended to cite reasons that we sort of broadly split into two categories. One was in the blue, people were concerned about things that could harm them or their family. They were concerned about themselves. What would happen to them? Am I going to get marketed to? Are there going to be negative consequences for my family? Can we trust that the data is going to be safe with them? Is the data going to be sold on? In the pink, the other half, the sort of 46%, align themselves with more social reasons. So feelings that commercial organisations having access to health data could have a negative impact on society. The idea of not agreeing that profit should be made, full stop, from NHS data, that organisations can't be trusted to put society before profit, they can't be trusted with the data, they could manipulate the data, this is unfair, and so on. So there's an interesting split here between personal and social concerns, and the social concerns in particular concern profit, the idea of profit conflicting with the beneficial ends of improving health for society. So there's a lot more I could talk about, but this is a bit of a whistle-stop tour, and I'm happy to answer any questions further about the research. But I just wanted to draw a few conclusions that would be pertinent to this particular discussion. Firstly, just to reiterate how low the awareness and understanding is of health data ever being used for purposes beyond direct care. So even within the NHS, even for compiling waiting lists, say cancer referral waiting lists, the idea of a person's health record being relevant to compiling that kind of data was a real struggle. Relating those abstract research purposes to personal health data, and why do you need my data for that, was a common question. Lots of confusion about identifiability, identifiable data, de-identified, anonymised, aggregate, anything personal level is perceived as my data, and I think this isn't helped by the fact that there's such a range of terms that are actually in use out there in the media, by researchers, by companies and so on. We do use lots of different and confusing terms. In general, more information leads to greater acceptance if there is a clear public benefit. And I think this goes slightly counter to a feeling that has been prevalent, which is a little information is a dangerous thing. I think there's certainly a concern about articulating how data is used and what the benefits are and what the risks are, that if you tell people a little bit, they'll get really worried. And if you get them to a point where you've told them a lot more, then they'll find things a bit more acceptable, they'll be more comfortable, particularly if they can ask questions. But there's a risk that if you just tell them a little bit, then they will really worry, they will opt out, they will raise all kinds of concerns. And this is a real challenge. I don't quite know how to address this. I don't think we can put the whole population through a day-long workshop. But in general, more information does seem to be a better thing. Also, just to reiterate, going back to the question around identifiable, non-identifiable data, people's concerns weren't just about my data and what happens to me. There was an interest in the social value of the data. Even if I can't be identified from it, I care what happens to it. It matters to me that it's used in a good way, irrespective of whether it's about me or not, which was something that I don't think we quite anticipated coming through as strongly as it did. A significant minority object to commercial access under any circumstances, and I think this raises some real questions around the kinds of opt-outs we might be able to offer for population level data. And this is sort of partly fed into the upcoming Caldecott review. And I think that one of the things we've concluded is what a need there is to develop some accessible narratives about how data can be used in practice. Not just saying this data is being used for medical research, but how, what data, what's involved, what's the purpose, what's the public benefit. Being honest about the risks involved, whether there's risks of re-identification. Robust red lines, I think, including for anonymized data, so clear statements about what data cannot be useful. Being able to articulate the safeguards and protections. So even though in the workshops this was not quite as, the people didn't feel quite as much that they needed to have information about this, they want to know that they're there. And providing an opt-out for people who object to their data being used in this way. So this research was published in March of this year. We are putting the quantitative survey data into the UK Data Archive because I'm sure there's quite a lot of additional research that could be done with that. We've been feeding this into the upcoming Caldecott review, which is around producing a new model for patient opt-outs from their personal data being used for purposes beyond their direct care. And it's also feeding into the Health Research Authority, who's undertaking some public dialogues to inform how the Confidentiality Advisory Group, which advises on data releases from the Information Centre, soon to be NHS Digital, should be used. One other thing that's happening is an independent task force is being set up on how to improve conversations about patient data. And this is going to be led by Nicola Perrin from our policy team. That will hopefully help figure out how these conversations can be had, being honest about the involvement of commercial organisations in the NHS and in research, to try and improve not only kind of the level of literacy that people have, but also to answer any questions straight up, hopefully avoid the negative perceptions of a lot of the media headlines that have dominated this debate so far. Thank you.